Welcome back to my house. I'm starting this. This is actually take two for those of you who don't know. I already went through several slides and found out that when you're recording, you cannot backtrack on a slide. So if I accidentally forward to a slide, I can't go back. And yes, I find that very frustrating. So this is going to be the last recorded sessions for the semester. Um, Chevy dog's out there chasing the birds. Uh, but hey, he's a good dog. That's what he wanted to go outside and do. He loves doing it. So if you hear some barking in the background, that's just normal. That's because you're in my house. I got my grandchildren here, my wife, a cup of coffee, and let's get comfortable and talk about hydration and the results of such, like your urinary system. Mm, that is good stuff. So the urinary system. Urinary system. Now, all too often we quickly review, because that's what this is. This chapter 33 is a review of the anatomy of the urinary system. We usually go over these anatomy reviews pretty fast because, let's face it, they are a review. You all have taken anatomy physiology. So this should just be a quick review. But certain systems really, really require more detailed analysis. And this is one of those systems. I'm here to tell you, come to a great understanding of the renal system, and you will understand medications and how the body works. Understanding how the body works lets you understand how disease impacts how the body fails to work because of the disease. And when then it lets you understand what the medication is doing to try to rectify that disease process. And so it gives you a better understanding. You understand what's normal. When it's abnormal, it really stands out. So that's why I say this is an extremely important chapter for you and for you to comprehend. Of course, always go over your learning objectives and make sure you got those. And let's talk about what is the urinary system. It's comprised of the kidneys, the ureters, the urinary bladder, and the urethra. The kidneys, you have two of them, the right and the left. The ureters, you have two of them coming from the right and left to the centralized bladder and then out through the urethra. So it's pretty simple. The kidney itself is made up of its own anatomy, which is primarily the renal cortex and the renal medulla. And those two are all illustrated on page 767. We're going to look at these illustrations. Excuse me. Let's first look at the illustration of anatomically where the kidneys are located in the body. Now let's look at this illustration. What do you see? What really leaps out at you? Well, when I look at it, I see those humongous blood vessels. Okay, I see a huge artery, which is basically the descending aorta, and that huge vein, which is the inferior vena cava. And I'm looking like that going like, wow, those are humongous. And they feed almost directly straight into the kidneys. What does that tell you? That tells you that these organs are extremely vascular, that their main job is blood, working with the blood and blood components. What does it do? It's got three functions. It's going to filtration. It's going to regulation, and it's going to produce. It actually creates certain products for the body to respond. So those are things that you have to remember. And how does it do it? It does it directly through that connection to the vascular system, because the actual functional unit of the kidney is what? The nephron. It is the nephron. Now, understand how the anatomy of the kidney works. It says you have the cortex. You look at the cortex and the medulla, and what is it designed? All that is it's a collection of nephrons all lined up all the way around. Each nephron receiving its own vascular supply from the renal artery. From the renal artery, it breaks down. Those blood vessels break down as they move out to the cortex to feed the individual nephron. That individual nephron eventually gets its blood supply, okay, at the individual nephron. You see at the top of this illustration, or you can look on your page 767, you see the afferent arterial, and you see that the blood comes into the glomerule, which is like this web, this capillary web that intertwines, this ball of blood vessel that is super small, that the blood is coming in, but it's coming in under pressure. This is where your blood pressure comes in, and this is where we talk about the dynamic of hydrostatic pressure. Since it's under pressure, it then forces fluid out of the blood vessel. Now that fluid is collected in the capsule, Bowman's capsule, and it moves along the capsule, follow along now on your illustration in your book, through the proximal convoluted tube. Now you'll see it shows H2O. It's being through osmosis. Remember, I talked to you about the three states that fluid moves, and it is going to be, fluid is moved through hydrostatic pressure, through osmosis, and through active transport. It's not so much the fluid that is moved, it is the particles that are moved through active transport. Active transport like the sodium-potassium pump that works with our intercellular and extracellular electrolytes. Now, for those of you in the 142 class, you're thinking, what is he talking about? But for those of you in my 240 class, you were going back and going like, oh yeah, I remember Mr. Kutchman talking about that. He mentioned that in the fluid electrolyte class when we got really into depth about each individual electrolyte. And this is what you're going to get to as a registered nurse. You're going to understand the body to the level of the microscopic level of electrolytes. And these electrolytes are being shifted. Now, if you look next to the H2O, you'll see, let's look at the bottom of the page. You'll see that little bracket that goes across the bottom of the page. And it says freely permeable to H2O. Then it says impermeable to H2O, and then variable permeable to H2O. That's each section of the loop that is going. Now, as the convoluted tubule, it's called convoluted tubule because it's convoluted, as it's moving around, that lets you know that, okay, water itself can freely move back and forth through that semi-permeable membrane. And so can sodium. The sodium can actually, the electrolyte can move. So sodium pushes out back in. What it doesn't show is that is actually wrapped with a capillary bed. And it's moving back into the blood system, the vascular system. So fluid moves back into, and then the metabolic waste, what's left over, continues down the tube. So we take back the sodium that we need in our body here at the proximal convoluted tubule, and the water follows sodium. So that's where osmotic diuretics are going to work. Osmotic diuretics work up high at the proximal convoluted tubule. Now here, these osmotic diuretics, they keep the fluid in the tube. It doesn't let the fluid go back into the bloodstream. So it draws off the water, which can be very, very potent diuretics. Osmotic diuretics are very potent, okay, because the diuretics make you urinate, make you lose water, right? That's why ADH, antidiuretics, help you retain water. Now, as you move down that tubule, you get to that big loop. Now, that loop is known as the loop of Henle. It is this area, even though you're seeing nothing but sodium, sodium, sodium. This is the area where Lasix works. Down here, the loop of Henle. Now, this is where you get potassium wasting diuretics. So up high at the proximal tube, osmotic diuretics. Down in the loop here, potassium wasting diuretics, okay, which are still very potent and very effective diuretics. Okay, but now you notice we're moving more into the impermeable section of the convoluted tubule. And as it becomes less permeable, you get less fluid shift. Now, that means the diuretics aren't going to be as potent. This is your potassium sparing diuretics. This is where things like aldactone work, all right, at the end or at the very distal loop of the convoluted tubule. This is where your potassium sparing diuretics, but they're not as effective of a diuretic. So this is why you see, if you really want someone to draw fluid off, you'll see the most potent diuretic you'll typically see used is Lasix. The osmotic diuretics are so potent that those are usually reserved for brain injuries, so that you can reduce the swelling on the brain. And they take very close ICU critical care nurse monitoring because they're so potent. So, and then understand that as you move more towards that distal loop, all right, that those are going to be the fluid transfer at that area is antidiuretic hormone effect. And that's going to, so that's how you understand how it works. And that is the functional unit of the kidney and how the diuretics work on the kidney. And knowing that is extremely important to understand your patient's health on how they're maintaining their fluid status. And if they're dehydrated, okay, hypovolemic, or if they're got a fluid overload, which could cause problems in and of itself, as you see in patients that have things like congestive heart failure. So I already talked about a little earlier about the functions of the kidney. You hear the doorbell going off. That's the dog coming back in the house. Huh, you done chasing the birds? Yeah. I said before that these are two filters that filter the blood, but they do more than just filter and eliminate metabolic wastes. They also regulate. They regulate the serum and electrolytes. They also, in doing so, they're going to regulate the pH balance. So they regulate your pH, that's your acid-base balance, which is extremely important. They regulate your electrolytes, which are extremely important. They eliminate metabolic waste, which we can't allow to build up in the blood. They regulate your fluid volume, which we have to monitor, keep at a certain level of homeostasis. So the filtration that it does results in regulation of all these things. But in addition to that, it is so closely tied to the vascular system that it actually regulates how many actual red blood cells you have through the creation of erythropoietin. The kidneys actually create and produce erythropoietin, so it tells the body to make more red blood cells when it needs more red blood cells. So your kidneys do that. Your kidneys metabolize vitamin D into its active form. So if it wasn't for your kidneys, vitamin D wouldn't be working for you. So it is actually the kidneys that metabolize the vitamin D into its active form for your kidneys to work. So you could say that it regulates vitamin D, or it helps produce the vitamin D in its active form. So these are the things that the kidneys do. And as it does this all through regulating the amount of fluid. And it's when it draws this fluid off your body, it has to eliminate that excess fluid somehow. And it does that through gathering it, drawing it through the ureters, okay? In your kidneys, it gathers it into your renal pelvic, or and you can look on page 767. It draws it out of the nephron into the renal pelvis, and from the renal pelvis all the way into the ureter, and from the ureter it drops down to the bladder. Well, if you look at the renal pelvis, and if you look at the calyx and the renal pelvis, the calyx is where it takes all the the fluid from all these different convoluted tubules and then draws it into the renal pelvis and then draws it into the ureter. That is where kidney stones form. And those kidney stones kind of grow, like almost like a, they gather up and grow in those little areas, and then they move. The fluid moves them, and when they get big, when they're small, they're no big deal, right? They're just kind of hanging out. But as the kidney stone gets bigger and bigger and bigger, then all of a sudden, boom, it lodges in the ureter, and it blocks the flow of urine. And then it acts like a dam. And then all that urine is still being produced because the kidneys are still doing their job, but they've got no place to go. Because you remember, the urine gathers, goes down, collects in the renal pelvis, and then flows through the ureters down into the bladder on the right and left side, and then the bladder expands and is just a holding organ. It's got muscles all around it, and it can hold about, a little over 1,000, maybe up to 1,500 cc's. And as it gets to a certain point, you feel the need to void, and then you go to the bathroom, and we do that on a regular basis. That voiding reflex is called micturition, and that reflex is controlled through the internal external sphincter of your urethral sphincter. Now, urethral sphincter has two sphincters, and the first one is autonomic, and your body's like, boop, gotta go, and you feel that urge to urinate, and you then control the second, and that's how you can release your urine at your controlled. You learn to control that. Hopefully, all of you learned that as little kids. And that's why when some people, when they're sleeping, they can have accidents all the way up until their young childhood years, because they have not learned this control of the external sphincter. And then once again, as people grow old with aging, they lose control of this, and they can actually suffer from incontinence. And this is why certain exercises can actually help strengthen these sphincters. And believe it or not, women who've experienced childbirth can sometimes experience incontinence issues, and there are strengthening exercises that can be taught and performed for them to help learn to control their urinary incontinence. But we'll talk about that more when we talk about the disorders of the urinary system. All right, so what happens when we talk about getting older? Well, what have I told you about getting older? You drink more coffee just to stay awake, right? Yeah. Oh. You got to drink that faster. It's getting cold. Nah, I drink more coffee probably for the caffeine. Well, there's all kinds of changes. There's changes in your renal blood flow. There's changes in your glomerular filtration rate. Why? Well, your blood pressure changes. Your hydrostatic pressure changes. There's all kinds of changes, but one of the biggest changes is the damage that can occur to your kidneys over the years of neglect. Prostate gland can swell up, starts to grow for men, and that becomes an obstruction. So that can become problematic. You get a decrease in renin production. Well, right there is your renin-angiotensin cycle. That has a huge hit on your blood pressure. Aldosterone, vitamin D activation. You don't empty your bladder quite as forcefully as you do when you're young, and that leaves residual urine in your bladder. Well, that's just a medium for bacterial growth. So what do you end up with? Higher incidence of urinary tract infections. So, I mean, there's all kinds of complications that occur with aging. I haven't really showed you too many slides where I said to you, growing old is a good thing to the body. It rarely is. So, I guess the only thing you can get is the maturity of the mind. Good luck with that. Your bladder doesn't hold as much as it used to, so you feel like you have to go all the time. It doesn't concentrate urine like it used to. So that means you actually are more dehydrated, you're drawing more fluid off the body, but that more fluid means you have to go to the bathroom more often. The tissue atrophies. There's all kinds of complications. These complications can lead to primary or secondary. They can be from primary hypertension, but they can also lead to secondary hypertension. And this is an important thing for you guys to Google. Google the difference, and this could be your homework assignment. Look up and review and read the difference between primary and secondary hypertension, so that you truly understand the difference between the one and the other, because they are important to understand. All right? You have to start asking yourself, which came first, the chicken or the egg? And you'll understand that comment more once you look up primary and secondary hypertension. Atherosclerosis, diabetes, all these things can attack the kidneys and affect the urological disorders. Of course, you can have obstructions, like I talked about. The kidney stones themselves can be obstructions, but you can also have other obstructions like renal stenosis, or we also talked about the prostate. I mentioned earlier the urinary tract infections. If you have a medium for bacterial growth, then it's likely to happen. Okay, so and then of course tubular necrosis. Fluid intake. Well, we take in about 2 to 2.5 liters a day on average. Now that's just our normal fluid intake. We do that through things like me drinking my coffee, you drinking your water. We have to take the fluid in to keep our homeostasis. Our body regulates the fluid in order to control and keep us at a normal blood pressure. But as I spoke earlier, blood pressure has a huge impact on your kidneys as a whole, on your kidneys' ability to do their job in order to filter the blood, in order to eliminate those waste products effectively. So it has to regulate the fluid. So what do? We also have to look at avoiding chemicals that could be harmful to your kidneys. There are certain things that have been known to cause kidney stones, and you should avoid. There are things that are good for kidneys and to help prevent kidney stones. So, Mediterranean diet is actually supposed to be very healthy for your kidneys. So there are things you can look at doing that is good for your kidneys, and what you can do to avoid. So they're here teaching, basic hygiene, practical hygiene to prevent urinary tract infections. Because as I said, urinary tract infections, showering regularly, cleaning regularly, personal hygiene. It also talks about how to properly wipe your bottom. All too often, females wipe the wrong direction, and they can actually wipe fecal material into their vagina and urethra, causing all kinds of problems. So women are obviously at a higher risk simply because of the fact that they have such a smaller urethra than men. Women have a very small urethra. Men have a much bigger urethra, and that it helps safeguard the bacteria from getting to your bladder. It's just a shorter distance for the bacteria to go for females. That puts them at a much higher risk. What do? Well, first test we do is urinalysis. Urinalysis is one of the most common diagnostic studies. I'll tell you right now, never order urinalysis without a follow-up culture and sensitivity. If that urinalysis is positive, you're going to want it to be cultured. Don't waste a urine and and not know what the organism is or how to treat it. If it comes back positive, you're definitely going to want to know what is the best antibiotic to use, and you do that by getting a culture and sensitivity. So a good institution will automatically have the policy that if a urinalysis is positive, they will automatically send the urine for a culture and sensitivity, period. Without it having to be ordered by a provider. Nothing would drive me more crazy as a nurse practitioner than ordering a UA, forgetting to order my culture and sensitivity, and having the lab throw the urine out after they ran the urinalysis, only to find out that it was positive. And now I have to go back and get another UA because they were dumb enough not to run the culture and sensitivity automatically. So hopefully you guys don't have to put up with that kind of shit. All right. General diagnostic tests, including CBC. Remember, we talk about CBC, we talk about, blood, urea, BUN, blood, urea, nitrogen. These really help, but the one that's going to really tell you kidney function is your creatinine. Creatinine clearance is important for you to know how well your kidneys are functioning. And that's the one you're going to look at before giving medications to patients. You're going to want to check your creatinine. All right, so CBCs are important, chemistries are important, because why? Well, the kidneys regulate. The kidneys help, the kidneys produce erythropoietin. So without that production, your bone marrow is not going to know to create red blood cells, so you might have a patient who's anemic. So that's why CBC is tied in. A chemistry, it's not listed here, but it's extremely important. Why? Because your kidneys regulate your electrolytes. So that's going to let you know right there. Your BUN, because it filters and metabolizes, metabolic waste. So your blood, urea, nitrogen is going to be huge. But the one that lets you know how well your kidneys are actually functioning is your creatinine clearance. That's the one to watch. All right? That's the one to watch. So, what type of radiologic procedures? Well, there's numerous types of radiologic procedures that you can do. In addition to those lab components, you have a KUB, kidney, ureter, bladder. It's a simple, it's done A and P, and you just, boom, straight on shot, you see the kidneys, the ureters, and the bladder. That's what it's called, KUB. And that's it. But more and more with the advent of CT and the dyes, you can do and see so much more now with a variety of tests that you use. And of course, don't forget your 24-hour urine. All right. And here's a question for you that you guys can send me back on email. I'll tell you what. The first one to answer me, I'll give some extra credit to you. If you guys send me an email, I'll give you extra credit if you can tell me. I'll tell you what I'll do. I'll give you an extra quiz credit if you can tell me what to do, the proper procedure on how to conduct a 24-hour urine test. Describe, okay, a 24-hour urine test, step by step. And I'll give you a 24-hour urine test quiz question credit. All right? So there's an extra quiz question for you right there in describing step by step in an email to me how to conduct a 24-hour urine. Now this is for my 142 class. 240, you guys don't get nothing. All right? You don't need no quiz credit, so quit your whining. You guys are getting over already. So, all right. Besides, if you don't know how to do a 24-hour urine yet by now and you're in 240, then we missed the boat. Hey, another test you're going to see that's very common is a renal biopsy, a punch biopsy that they're going to do. And they do it, why? Well, hey, they're checking for cancer. In any procedure that's an invasive procedure, you always, I don't know why they put this up here for renal biopsy. Guys, any invasive procedure, you're going to explain the procedure for the patient. You're going to explain the purpose, why you're doing it. You're going to explain the procedure so the patient understands it. You're going to explain what they're going to go through. You're going to explain what they're going to experience after they've gone through it. And you're going to always give discharge instructions for teaching. So this applies to any invasive procedure you might have with a patient, let alone a renal biopsy. This just illustrates where, okay, that's actually not their front, it's their back. Yeah, not a comfortable procedure, but they are numbed up. So what are we going to do to measure urine function? Well, what do you think? Eyes and nose, intake and output. You measure how much they're taking in orally versus how much they're urinating. Your eyes and nose should always balance out. They should come close to being almost balanced. Boom, boom, right? You record daily intake, daily output. We don't do a good job of that. And I'll tell you what we do a horrendous job at is what's one of the best ways to tell if a patient is retaining fluid? Daily weights. Daily weights. Weighing the patient lets you know. Not only does it let you know, but it lets you know exactly how much fluid that patient's retaining. Because if you remember back in dosage calculation, we taught you how to convert weight to mLs. That's right. That's right. I remember now. 1 kilogram of equals 1 liter. Yes. So you can actually figure out how much they're retaining by how much water weight they've gained. And you can, but here's the thing. You can only do this, daily weights only work effectively if you get an accurate weight on the date of admission. And we don't. And this is one of my pet peeves because it provides a provider with a lot of information. We as nurses underestimate the value of intake and output in daily weights. And I have seen patients that have literally, according to the hospital records, have gained almost 100 pounds in like 3 days. They didn't gain 100 pounds. They were never weighed on admission. The admitting nurse, instead of taking the time to get a bedside scale, and let's face it, how many patients do you come across that are completely bedridden, that can't stand at bedside with some assistance? If they can stand, you can weigh them. And even if you have to weigh them in bed, you should weigh them with only standardized items in the bed. Remove all the pillows, remove as many blankets as you can, and only have the minimum amount of bed linen. And make sure that the patient is in a hospital gown. And that they're weighed with the same material as you're going to use a bed scale, that they're weighed with only the same items in the bed every single time, so that you're still getting as accurate of a reading as possible. That is how important true daily weights are, to do them right. But to do them right really enables a provider to manage their therapeutic regimen. And when you don't give them the information that they need, it makes it so much harder for them to do their job. So, in addition, you want to know, are they having a regular flow? What's the characteristics of the urine? You guys all know it should look amber. It should be somewhat see-through. It should not be cloudy. It should not have a foul smell. All right. It shouldn't be painful. It shouldn't burn. It shouldn't be discomfort. All right. If they're experiencing any of that, something's obviously wrong. So, the changes. Olguria is less than 30 mLs an hour. Anuria is no urine production whatsoever. 30 mLs an hour is what is normal. You want to maintain urine output to at least 30 mLs an hour. Now, polyuria is a high amount. Well, what's considered high? Well, that depends on your patient and the conditions. If you have a patient on an IV and they're on oral fluids, you might be getting a little bit more than 30 mLs an hour, and that could be okay. But you just have to then back it off. You balance it based on your I's and your O's, and they should balance. But if you're not getting accurate I's and O's from your nursing staff, you can't really balance that fluid properly. All right? So you need to know, the frequency. You need to know on any issues like hesitancy. Is there urinary retention? So you might have to go in there and do a bladder scan and let me know. That way they might have to go in and do an in and out cath, or they might have to place a Foley catheter. We want to avoid Foley catheters or catheterization at all costs. Why? Because catheterizations lead to urinary tract infections. We want to avoid urinary tract infections. So what do? We evaluate the color, the odor. We look for things like blood in the urine, pneumature, that's actually air in the urine, which can happen. And we look for patterns. The pattern to look for, the one I was always taught was urgency, frequency, pain. Do you feel like you have to go all often? Right? Are you going often? And does it hurt to go? Burning, painful sensation. Are you experiencing any back pain, lower back pain? Okay, that can hurt. That can be an indication of kidney stones. So here are some of the nursing diagnoses: impaired urinary elimination, urinary retention, fluid volume excess, pain related to urinary spasms, activity intolerance. So what do we want to do? We want to make sure that they don't get a urinary tract infection. So absence of infection, absence of pain, restore normal urinary output. In other words, we want to restore fluid balance. Appropriate self-care. Okay, we want to prevent any type of further complications. We want to make sure we're doing I's and O's, body weights. Look for any signs of edema, especially peripheral edema. But that fluid can be held in other locations. So always check for and monitor nephrotoxicity. Urinary retention is important. You can do that through a bladder scan, but always check how well your kidneys. Take a look at your creatinine clearance. Ask yourself, are my kidneys functioning appropriately? Maintain proper aseptic technique. Avoid infection. And once again, proper I's and O's, strict I's and O's, proper daily weights. Just how you place Foley's, you guys learn that. Urinary catheter care is extremely important. We do not want any hospital-acquired nosocomial infections. You buy that, guess what? The hospital's not getting paid for that patient's stay anymore. And that directly impacts your income. So do it right. When's the right time to do the right thing? Right now. Okay. I said before, BUN, creatinine. Always look at, if ever your patient is on a diuretic, typically, especially Lasix, always check your potassium prior to giving a potassium wasting diuretic. Get in the habit of looking at your electrolytes, okay, your chemistries before giving any diuretic anyhow. It's important to look at your lab values, okay? It's important to understand your lab values. Okay, considerations for your aids. When it comes to bladder training, we'll talk a little bit more about that and disorders of urinary. Some of your common problems, especially with elderly, is urinary incontinence and urinary retention. You will see both. They're both ends of the spectrum. One, they can't hold any urine in their bladder, just leaks out. The other one, they can't go because they just can't release the urine. Then they're both huge problems. So, what causes some of the urinary incontinence? Well, enlarged prostate, obstructions, spinal cord injury, neurological disorders, functional disorders, basic immobility, not being able to get out of bed to go, urinary tract infections, menopause, obesity, endocrine. I mean, there's all kinds. That's why it's multi-parity. All kinds of things can cause incontinence. Yeah, you have to try to find the underlying etiology and try to resolve it. Okay, we already talked about some of the underlying pathophysiology of the internal external sphincters. If a patient isn't conscious, that they can't control, so urinary tract infections can lead to incontinence. Uh, these are all things we just talked about on the slide before. So, what types of incontinence do you have? You have urge incontinence. This is voiding when there is strong urge to go. In other words, this is where you see with children. They wait too long and they just got to go. You see them, they start doing the pee-pee dance and boom, they can't hold it. Stress incontinence. This is where you see in some middle-aged women who may have had a couple children. They sneeze, they cough, the muscles aren't as strong as they used to be, and boom, they have a minor leak. They could have a mixed, a combination of the two. They could have overflow incontinence, functional incontinence. Functional is the cognitive inability to feel the urge. This could occur after someone like a neurological disorder or a neurological incontinence from a spinal cord injury. Functional incontinence could be from a stroke. So you have to basically carefully diagnose what type of incontinence it is, obviously. And then there's things you can do, exercises to strengthen the pelvic floor. There's also vaginal weight training exercises to help with the pelvic floor. And of course, if obesity is an issue, trying to get to a normal weight also helps. That additional weight puts pressure on the bladder internally from the abdomen, and that can cause incontinence. So reducing that weight removes that stress or that pressure. Okay, if there's an atrophy due to menopause, then estrogen therapy can help. That's where we get into medications and biofeedback. There's all kinds of physical therapy that can be done, that can be conducted as an inpatient or outpatient. All right. We talk about there can be surgeries performed to help with the incontinence as well, and you can actually have an artificial sphincter implanted. Hey, you don't have to just face this in a matter-of-fact approach. At the end of the day, these are body functions that we all perform. And you're going to have to just be matter-of-fact, talk to them, and try to get a voiding schedule and a voiding diary. And you're going to have to assist, and it's actually toilet training. Kind of like you did when you were a little kid and when you just don't remember it. But you've already been through this. And you see this a lot in elderly. You want to avoid, obviously, caffeine, alcohol, certain beverages can cause, and also you want to monitor fluid intake because, like I said, you want to balance their eyes and nose. Urinary retention, that's when they cannot void. You can have acute urinary retention. Now, we see that often in the hospital. Someone comes out of surgery. They might have just an acute episode where for the first couple hours they can't void, and we have to just put in sometimes it's just an in and out catheter. Sometimes we have to place a Foley for a set period of time. All right, double void. Residual urine, sometimes that can happen where they go and they just don't, not all the urine is removed from the bladder, and they have residual urine, and that can cause problems as well. So the urinary system is a complicated system. It does a lot for the body. It's important for you to understand everything that it does do. Remember that while it filtrates, it filtrates to help eliminate the metabolic wastes. So it's going to filter the blood, but it filters, it regulates, and it produces. So those are the things that are extremely important to the kidneys for the urinary system. Those active components. And if you understand, if you go back and really take a look at page 767, and really look at figure 33-3 and understand the whole functional unit of the kidney is the nephron itself, and how it works and is tied to the vascular system, you'll really have a good grasp of the renal system and everything it does for the body, and the medications and the impact those medications have. All right, you guys have a good day and take care.